I'm Leon Platanes. I'm the director of the Lurie Cancer Center. I would like to welcome all of you to this special talk today about COVID-19 for researchers and staff, and some suggestions for precautions and best practices. And I'm very grateful to our speakers, Michael Ison and Michael Angarone, who agreed again to come here with us today. They gave grand rounds a couple of months ago that were very interesting and massively attended. And we very much look forward to their presentation. There will be brief presentations by them, and then we're gonna have a discussion. If you wanna ask questions, you can see on the screen, you can email them to cancer@northwestern.edu. Then they're gonna come to me and I will ask our guests. So our guests again are Mike Ison, and everyone knows Mike. He has been a key figure in driving the COVID response here at Northwestern. He's a professor in the Division of Infectious Disease and Organ Transplantation, and he's the medical director of the Transplant and Immunocompromised Host Infectious Disease Service. And Mike Angarone is an assistant professor of infectious diseases and organ transplantation. And he has also done a lot of work with viruses and with a COVID response. So we are grateful to both of them, and we can go ahead and start. I guess, Mike, you want to start?
Sure. I just need access to share the screen. There we go. Great. So what I thought I would do today is just give an overview and update on SARS-CoV. It definitely won't be as detailed as it was for the grand rounds. So here are my disclosures. So just a little bit of background about coronavirus. Coronaviruses are enveloped single-stranded RNA viruses. There are a number of coronaviruses that cause clinical disease, typically colds in people seasonally, both alpha and beta subtypes. These typically happen in the fall and the spring of most years. Animal beta coronaviruses have been associated with severe clinical disease 3 times: SARS-CoV-1, 2002, MERS-CoV, which is ongoing starting in 2012, and then the current SARS-CoV-2, which started at the tail end of 2019. The schematic of the virus is shown here, where you can see the RNA, which is that studded red line in the middle, surrounded by a enveloped protein with proteins studded within the envelope. The most important one that we focus on is this yellow spike that is coming out from the surface. This is what allows the virus to bind to the receptor, the ACE2 receptors, and is the main focus of our neutralizing antibodies. If antibodies bind to that spike protein, particularly when it's in the unfolded form, it prevents the virus from infecting new cells. We have experienced a pretty robust epidemic and pandemic of this virus. It's hard to believe. We really started to recognize this as a global threat only about 6 to 7 months ago. On the top of this is a schematic that shows you where the virus was predominating, and you can see earlier on in the year we had disease mostly in Europe and then affecting predominantly the United States. The bulk of cases now are in Southern and Central America, although, as we all are aware of, the cases in the United States are unfortunately increasing. This is a heat map showing areas that have a huge amount of COVID-19 going on. There's been a lot of press about places like Texas, Florida, Arizona, and particularly Southern California. But I think the thing that's concerning, especially looking at these heat maps over time, The states surrounding Illinois have been getting warmer and warmer, meaning that there's more and more cases. And of great concern is over the last 2 days, we've had a much higher number of cases reported in the state of Illinois. We are hovering at around 950 or so. And yesterday it was about a little over 1,500, today a little over 1,600. And where I'm concerned is if we know a lot of people are going up to Wisconsin, Indiana, and Michigan for vacations and maybe getting infected and bringing that back to Illinois. Looking at our experience here in Illinois, as with most places, the cities have been heavily affected. But I think that there was a lot of consternation about whether or not the suburbs were as equally affected. And in fact, if you look at the residents of where people were living with a diagnosis, you can see it wasn't just a Chicago problem. It was an entire Chicagoland area. And as we all know, people move back and forth between the suburbs and the city. And so we need to be very thoughtful of this as we, again, see expansion of numbers. Most cases have been in the more urban parts of the state around the Iowa border, Peoria, Springfield, and then a huge number of cases where we're seeing the biggest rise down near St. Louis. In terms of gender, it's about 50-50 with a slight predominance for females being diagnosed. And while there's a relatively equal distribution of diagnosed cases, mortality is highly overrepresented in the African and Hispanic population. Next, looking at who's getting diagnosed, there is a very robust proportion of the population that's young, less than 50 years of age, and they actually account for the most cases and have for the longest time. Thankfully, their mortality is low, but not zero, but it really does have a significant mortality risk among the older adults. I do want to highlight, because there's a lot of question about how bad disease can be among younger individuals. There are deaths, there are severe diseases, and I will just highlight our first lung transplant for COVID-19 was in her 20s. So really, just because you're young doesn't mean that you're immune from getting sick. A number of risk factors have been identified as potential for requiring hospitalization or needing ICU level care in patients with COVID-19. As I mentioned before on the last couple of slides, age is a major underlying factor. Underlying medical problems, particularly pulmonary disease, chronic kidney disease, diabetes, hypertension, cardiovascular disease. Obesity is a huge risk factor, particularly for the younger population. In fact, it's the predominant risk factor for many of our patients that are being hospitalized under 50. And then ethnic minorities, Hispanic and African Americans. A number of biomarkers have been identified as potential markers for patients that are more likely to progress. Then looking a little bit about the clinical presentation and disease course. This is coming from the ICERIC cohort, which is predominantly British, but includes global representation of cases of COVID-19. It's focused on patients that are hospitalized with disease. And so you see an older and slightly male predominance in those patients with COVID-19 requiring hospitalizations. In terms of underlying medical conditions, again, you can see those cardiovascular conditions, hypertension, chronic heart disease, diabetes and lung disease being the most common subtype, but there are some differences based on age. So asthma is a much greater driver for young adults, whereas dementia is a greater risk factor among older individuals. And again, as I mentioned before, obesity really seems to be a greater risk factor among those patients that are a little younger. In terms of clinical presentation, even the most obvious symptom, fever, is only present in about 70 to 75% of adults. Shortness of breath and cough followed thereafter. And most of the other symptoms are present, but in less common frequency. Again, there's an age driver. Older adults are less likely to have fever. They're more likely to be confused on presentation, and again is a key driver for which population and which symptoms you would expect in various age groups. In terms of hospitalizations, you can see that average length of stay is very much age dependent, very short for very young individuals, and much more prolonged in older adults. At day 14, so 2 weeks into the hospital course, only about 40% of patients have been discharged from the hospital. So prolonged hospitalization is definitely a challenge with these patients. In terms of testing, we've done a good job of expanding testing in the United States, but still lag behind many other countries in the world. And this heat map put together by the Kaiser Family Foundation really shows adequacy of testing in terms of number of tests performed per day per population. And there are some states that are doing great, California, New York, and Florida, others that are doing better than the most, including Illinois, but there's still room for improvement. But you can see the majority of states still are under testing relative to where they should be. In terms of antibody response, this is something I'm only going to talk about very briefly. Antibodies typically come up relatively soon after clinical illness, with patients generally having positive results between day 3 and day 7. We started doing work in part supported by the Cancer Center to look at serology in our patients that are severely ill, as well as those patients that have recovered from COVID-19. And what we're finding is that those patients with mild outpatient disease have relatively low levels of antibody compared to our more severely ill population that have much higher viral loads. In terms of how long these antibodies persist, we don't really have a good answer. There are some hints that these decay, particularly in patients with milder disease. How long it takes for them to decay will take time to recognize. Likewise, we're starting to do vaccine studies where we'll be able to see what is the amount of antibody that we need to protect us from new infections. And until we get that information, it's hard to tell what the optimal goal antibody titer should be. Transmission, I'm going to spend a few minutes talking about the importance of masking and how beneficial they are. First, a very science-focused paper that came from the group in Hong Kong that's done a lot of work looking at transmission of different viruses. They looked at seasonal coronaviruses and influenza, and as you can see in patients that are sick with these infections, if you swab the nose or the throat, you see a fair amount of these viruses detectable by swab. If you have them breathe comfortably without a mask, you can see that several patients for flu and coronavirus have virus detectable in the air around them. Once you apply a mask to these patients, you no longer can detect the virus. So again, highlighting that there is, in a patient with actual disease, clear benefit to the use of masks. And from studies, and I don't like to put percentages of protection on here because there's a lot of variables that go in this, but I think it gives us some sense to see from experiences that have been gained over time about the risk of transmission. If you're in very close proximity and either you or the asymptomatic COVID patient is near you, you have the highest risk of contracting COVID-19 from that individual. If you're wearing a mask, it reduces the risk slightly. If they wear the mask, it further reduces the risk. And if you both wear a mask, it reduces the risk greatly. And there was a great case that came out a week ago in the MMWR, in which there were two individuals that were sick in a salon. Everyone in the salon had a mask on throughout the entire time that they were there, and no one became sick, really highlighting how important it is to wear a mask. And it's important, probably more important, that the asymptomatic carrier wear the mask than the contact. And the reason for this is people oftentimes don't have symptoms the day or two when they are able to transmit infection. then progress on to requiring symptoms later on in the clinical illness. And what you would feel terrible about is if you didn't wear a mask, felt bad yesterday, and realized how many people you could have infected by not wearing a mask. So it's really essential. Everyone should be wearing a mask when you're not on your own. Changing direction briefly to talk about vaccines and where we are. It really is a miracle how far along we've gone in terms of the development of a vaccine. There's one mRNA vaccine that's approved for the military and being used in China. There are 4 vaccines that are entering phase 3 efficacy trials. And most of these vaccines are using mRNA or DNA technologies. Some are utilizing live viral vectors, and I'll talk about these in a second. And the ones that I think I'm going to be very interested in are moving along, but a little bit slower, and those are protein vaccines. So most of the vaccines, and in fact, 4 of the 5 vaccines that are being moved forward as part of Operation Warp Speed are these RNA or DNA vaccines. The way that these work is that either RNA that's either naked or encapsulated, or DNA is put into this to the muscle. This is then transfects cells that start making the protein that the RNA or DNA encodes for. So your cells then start expressing the spike protein, let's say, on the affected cells. The body then responds by making antibodies, and you're protected. The advantage of these is you can scale up production very quickly. If there's mutations, you can change them very quickly. I think the key downside is that these are relatively new. There's a lot of vaccines that are under clinical development that use this technology, but not many there are currently none that are licensed. So long-term safety and uptake in the community is not well understood. Viral vectors, one of the 5 vaccines that's moving forward uses this approach where you have a virus, in this case a monkey adenovirus, that infects the individual, replicates a component of the SARS-CoV protein, again inducing antibody. And then further down in the pipeline are the protein vaccines. These are just like our regular flu vaccine, except it's SARS-CoV. These take a lot longer to produce, have challenges because you oftentimes for novel viruses need very high amounts of protein to trigger a immune response, and may need adjuvant to strengthen that immune response. These have a longer track record, but take a lot longer to develop, and that's why they're lagging a little bit behind in terms of their development. In terms of management, we've come a very long way. We basically have 3 general approaches in which we can prevent infection or affect the disease course. The first is through the use of antiviral therapy, and remdesivir was the first drug to get authorized for this indication. It prevents the virus from replicating and should reduce the amount of cytokine production and clinical recovery. And in fact, it was shown to speed recovery by about 4 days. Other antivirals are on their way, including the first oral antiviral that clearly we would be greatly interested in. Next are antibodies, and these can either be pharmaceutically made monoclonal antibodies or convalescent plasma or pooled antibodies. These work by binding to the virus, and so that can help prevent the virus from infecting new cells, as well as helping clear these viruses and speed recovery. Lastly, there's been a lot of effort focused on modulating the host immune response. Unfortunately, some disappointing information on the IL-6 receptor blocker, sirolimus, which may have impact for some of these studies. More studies are ongoing to look at this role, and in fact, a broad-acting immune modulator, dexamethasone, a steroid, was shown to be associated with clinical improvement and recovery in patients with more severe infection, and is now used much more broadly in our patients. Lastly, I know a lot of people have questions about what the future holds. We're on the cusp of entering the fall when flu and other respiratory viruses may co-circulate with COVID-19. How this will affect the flu season is unclear. A lot of it will depend on how well people do with masking. It's possible if people are very diligent with masking, restrict their movement, we may actually have a relatively mild flu season. There's potential that the viruses could interact with one another, preventing infection with the other. We'll have to wait and see. But I think the unfortunate thing is we've seen kind of, instead of a nadir during the summer, which is what I was hoping, we've seen what looks to be perhaps an even bigger wave here in the late summer because people didn't do the right thing, open slowly, mask carefully, wash their hands, and not come to work or school if they're sick. So that's a bit of an overview of kind of approach and prevention of COVID-19. I'll turn it over to Leon to introduce Mike.
Yeah, Mike is also from the Division of Infectious Disease. He's assistant professor there, and he has been also very active in the overall COVID response. Really happy he's here with us today again. Thank you, Mike.
Yeah. All right, thank you everyone for allowing me to talk. I'm going to talk a little bit more on COVID in cancer, patients with cancer. Here's my disclosures, and kind of what I'm going to focus on is what do we know and what are we learning about COVID in persons with cancer. And so there is growing data on the course and outcome of COVID in persons with cancer. There's definitely a concern for higher rates of infection, worse outcomes in this population, concerns that there may be transmission events in the hospital or other healthcare environment, and then concerns about what do we do for the management of our cancer patients who have SARS-CoV-2 and are getting chemotherapy or require chemotherapy. So early on, there was a recognition of the incidence of SARS-CoV-2 in cancer patients being higher than the general population. This is a case series out of Wuhan University that looked at individuals with cancer, and they found an incidence rate that was about twice as high as the incidence rate in the general population. More specifically, they found that this population was older, so over the age of 65, and then really the predominant cancer that was seen was non-small cell lung cancer. And they did find 3 deaths within this population. Very small numbers, but this was giving us a hint that maybe there was more of an impact of coronavirus infection in our cancer patients. When we look at the prevalence of cancer in persons with COVID, so this is just looking at multiple series that have been published and how many of those patients within those series have cancer and what's the prevalence of cancer within those studies. In the small population studies, it's around 3%. The larger population studies, the studies that have over 100 patients that were included, it was about 2%. Overall, about 2% of the patients that were being found with COVID or being reported on with COVID had cancer. So showing that there was a substantial burden of coronavirus within the population of individuals with cancer. So then that started us to look at, well, what about the presentation and the outcomes in our patients with cancer that have COVID? And is it different? So are they progressing differently? So Mike talked about the presentation and how there's going to be individuals that develop severe disease requiring mechanical ventilation and death. What about those individuals with cancer, and how does that compare with the general population? And there's a few studies now that are coming out starting to look at this and break this down with a little bit more granularity. So one of the first studies looking at just the comparison of cancer patients with coronavirus and non-cancer patients with coronavirus showed that cancer patients with coronavirus were hospitalized more frequently, had more of a smoking history. They had higher observed death rates, higher rates of ICU admission, and higher rates of mechanical ventilation, is all seen here in kind of this graphic representation of the data. Interestingly, looking at the symptoms, there's really not much of a difference between the symptoms and the presentation of individuals with cancer and those without cancer for coronavirus. A more recent study looking at the experience at Memorial Sloan Kettering, just looking at the kind of breakdown in the age groups of those individuals who developed COVID with cancer versus kind of the general population in New York City at the time, really showed that the distribution in terms of the age distribution skewed a little bit to older for individuals with cancer. I'll talk a little bit more on the outcomes, but the outcomes were kind of more widely distributed through the age groups, and more of these patients probably requiring hospitalization themselves. So looking at many of these different studies that are out there, kind of focusing on the cancer type and individuals with cancer, are there certain malignancies that we should be worried about? And I actually thought that this was somewhat interesting. So looking at kind of the 4 largest studies that have been published so far. So the Memorial Sloan Kettering experience, well over 75% of the patients that were included in this study that had coronavirus infection had solid tumors with the predominance of breast cancer, colorectal, and lung cancer as the 1, 2, and 3 cancers that were identified. The COVID Cancer Consortium, which is a large consortium of cancer centers in Spain, other areas of Northern Europe, the UK, and the United States. Again, solid tumors were the predominant cancers that were identified. In this group, it was breast, prostate, and GI. The UA Coronavirus Cancer Monitoring Project, which monitors the coronavirus infection in individuals with cancer throughout all of the United Kingdom, again, identified solid tumors as being the predominant cancer, GI, breast, and lung being the predominant cancers. And then the Wuhan study that I alluded to, again, showing solid tumors as being the predominant cancers in lung, GI, and breast. And so that kind of left me a little bit surprised and wondering, well, what about the heme malignancy patients? And only about 10 to 20% of persons with COVID and cancer fall into the heme malignancy group. And interestingly enough, most of those have lymphoma or lymphoid cancers. There's also been a lack of representation of individuals that have had stem cell transplant, which I think, again, is pretty surprising. There's a couple of hypotheses for this. Heme malignancy patients, especially those who have stem cell transplant recipients, tend to isolate themselves to begin with. They more frequently wear masks or try to stay away from large gatherings. And so that's a hypothesis that's going around as to maybe why the heme malignancy in the stem cell population have not been affected as much as the solid tumor population. When we go back to the clinical presentation, so this is, again, early out of China. Fever, cough were the predominant symptoms, but again, as Mike mentioned, not 100% of the individuals. So about 80% had cough or fever. This was also seen in the Memorial Sloan Kettering experience, fever and cough being seen in about 75 to 80% of individuals. The other symptoms, fatigue, dyspnea, myalgias, diarrhea, chest pain, occurred with less frequency in individuals with cancer. In this Chinese study, about 50 to 60%, the Memorial Sloan Kettering experience, about less than 50% presented with dyspnea, fatigue, diarrhea, and some of the other symptoms that we really try to look for in our individuals that have a coronavirus. It was interesting in the Memorial Sloan Kettering, they had very few individuals with loss of smell or changes in taste, which was a symptom that was recognized kind of in March, April, as we started to see more cases in Europe and the United States. When we look at the progression of disease, so this, I think the most important components with coronavirus in our cancer patient population is progression and outcomes. And then lastly, what do we do with chemotherapy? With progression of disease, one of the early observations was that individuals with cancer were more likely to end up in the ICU, were more likely to need mechanical ventilation, and were more likely to die from their infection than counterparts that did not have cancer. And this was both for individuals with active cancer and those with a prior history of cancer, so that may have had chemotherapy months or years before. And so it was really interesting that history of cancer also played into poor outcomes in this population. Follow-up within this population also looked at the risk of severe disease. And again, severe disease was more common in individuals that had a history of cancer than those without. And so really kind of making us worried about what was going to happen with our patients with cancers. Again, going back to the Sloan Kettering experience that was just recently published, looking at the hospitalization and deaths. The hospitalizations were kind of spread throughout all age groups, so the young as well as the old, which is a little bit different than what we're seeing in the general population or non-cancer population, where really it's the adults and then the older adults that are predominating in the hospitalization category. And so this was kind of a unique finding within this cancer population that younger individuals were being hospitalized. When we looked at the deaths kind of fell in the same category of individuals. So it fell in those older individuals, so those that are 65 and older. But again, there were deaths in the younger population. I think what's interesting is the death rates were still somewhat on the lower side than in the general New York population as a whole, which I think is something that is very interesting as well. When we go back to kind of breaking it down based on cancer type or chemotherapy use, so this Chinese study looking at the breakdown based on cancer type really showed that even though not as represented, the hematologic malignancy group and lung group suffered in terms of mortality, in terms of more severe disease, that being ICU admission or critical being put on a mechanical ventilation. When looking at chemotherapy use, individuals taking immune therapy or recent surgery tended to have poorer outcomes than individuals on standard chemotherapy or radiotherapy. Why the recent surgery played a role was a little bit surprising. It may be that those individuals were recovering from their surgery and just sicker at the time when they acquired their infection, as many of the surgeries in this study were recent surgeries, so within the week or two before the diagnosis of coronavirus. When looking at the mortality, so this was the WHO kind of doing a review of the China experience with coronavirus. The mortality of individuals with cancer was around 7.6%. So fairly high, and when compared to the overall mortality of 3.8%, was about twice as high of what we were seeing in all comers, much higher than what it was seen in individuals with no comorbidity, and a little bit less than those with cardiovascular disease, but comparable to those with diabetes, hypertension, and chronic respiratory illness. When looking at chemotherapy and its impact, this study just looked at individuals that got chemotherapy within 14 days or longer than 14 days from their diagnosis of COVID, and individuals that had received their chemotherapy within the 14 days of their diagnosis of COVID were more likely to develop more severe disease than those individuals that had chemotherapy beyond 14 days from their diagnosis. And this was kind of mirrored in the UK experience, and the UK experience just at all their cancer patients that were put into this registry. And so if we look at the individuals that were on cancer treatment, receiving chemotherapy, about 26% of those individuals ended up dying, and they made up about a third of all the individuals that died. So a substantial impact, I think, of cancer itself, but also the chemotherapy impacting the outcomes in these individuals and these patients. And so kind of where are we at with continuing chemotherapy and what should we do? Many of the guidelines, organizations, and large national and international organizations are really kind of stressing that, you know, immune suppression and the cancer itself is probably putting our patients at a very high risk of complications, including death from coronavirus, that we should probably really consider interrupting chemotherapy for individuals that get a diagnosis of coronavirus or COVID-19. We should resume when we know that symptoms have resolved, and maybe even looking at elimination of the virus from the individual by using nucleic acid tests to look for virus itself. We do know that this may be difficult, that these individuals may shed virus for very prolonged periods of time. So it may be more important to look at the resolution of symptoms. And then if the cancer is rapidly progressive and the benefit of the chemotherapy outweighs any perceived risk, then it's okay to proceed with cancer treatments and chemotherapy, but having that discussion with the patient as well as all other individuals involved in the care of the patient. So kind of in conclusion with COVID-19 in persons with cancer, presentation seems to be similar to those without cancer, with mostly fever and cough. Prevalence seems to be higher in individuals with cancer for SARS coronavirus 2 infection, and outcomes appear to be worse. So more severe disease, more ICU admission, mechanical ventilation, and death. And then looking specifically at conditions that may portend more severe disease or outcome, it's solid tumor, and then some of these immune checkpoint inhibitors with which some of the solid tumor cancer patients are receiving for their chemotherapy. So with that, we'll go to questions.
Okay, great. Thank you very much for these presentations. They were both very interesting. Again, if you have questions, please email them to cancer.northwestern.edu and they will come to me and ask. And let me start with the first question that I have, and that's for Mike Ison, actually. So from what we know this moment, approximately 35 to 40% of the cases of transmission of COVID are from asymptomatic individuals, and that has been the big problem. One thing that is not clear to me, and I don't know if you have any more information, is how many of these people really are asymptomatic in the sense that eventually the virus clears, and how many of them are just pre-symptomatic with long incubation rates. Is that something that we have any information right now?
Yeah. So that's a great question, and there have been a few studies that have looked at this. Truly asymptomatic, meaning they never have any symptoms with very detailed questioning, is very unusual with this disease. In most of the studies, it's been 10 to 15%. What is more common is posse-symptomatic, so where someone has symptoms, but they may not even realize that they were sick. Maybe they're feeling tired and a little achy. I can assure you probably in the last 3 months, I'm COVID negative. I've had a couple of days where I woke up by antibody. I have woken up and felt a little achy and my neck's a little stiff. I don't think anything of it. I might have a fleeting concern that I'm getting sick, but, many people have symptoms when carefully questioned, so they have minor symptoms that they may not appreciate. The bigger proportion of patients, so 70% or so, may have no symptoms or may feel off for a day or two and then become truly symptomatic with fevers, cough, whatnot. So the majority of people eventually do become sick or have some symptoms when questioned very carefully.
Okay. All right. Thank you. At this point, I would like to ask Munshi, who oversees a reopening committee we have in the Cancer Center, to ask directly a question. Munshi, go ahead.
I think, thank you. I very much enjoyed the two presentations. The questions I have mostly in the spectrum of what I would call infection control. And how do you deal with that? Because the issue that comes up in the lab is how do you do social distancing? How do you do masks? That is not a problem. The question we have had 3 issues that have come up in our meeting, in our weekly discussions. One of them is if somebody turns up positive in your lab, say you find out they were outside or interacting with people, and suddenly they have some symptom, they get tested, and they are positive. Then what should be the right thing for the PI to do? Should they test everybody? Should they? So give me a sense of what your thoughts are as to what should we do from the infectious disease point of view and from the policy point of view. So 2 separate questions that comes into play.
Yeah. So one of the challenges is it depends a little bit on the lab and who's involved, because there are slightly different processes for university employees versus medical employees that have appointments at Northwestern Medicine. If they have an appointment at Northwestern Medicine, they should call the COVID hotline and get guidance from them. In general, the approach is it depends a little bit on the type of exposure, mask wearing, and the like. If the person was masked the entire time they were around other individuals, the risk of transmission is relatively low. And so generally the guidance is to continue allowing the person to come to work, continue wearing the mask, and monitor the patient, the exposed individuals for symptoms. If they do develop symptoms, then again, they should reach out to their doctor to get tested and evaluated. If you had a higher risk exposure, someone wasn't wearing a mask, for example, they were in the break room, whatnot, again, probably the best thing to do is to reach out to one of the physicians to help you think through the kind of the risk and the approach. But again, generally, if everyone's masked and people are without symptoms, the risk is relatively low for that individual. I don't know, Mike, if you got other thoughts.
Yeah, no, I agree. I think, that's where it becomes really important to have masks and also kind of look at your labs or your environments as kind of pods. I think having people working together in those pods, so now you're cohorting in a way individuals amongst themselves. And so as Mike mentioned, if everyone's wearing a mask, if the individual who ended up getting diagnosed with coronavirus was wearing a mask, the risk is relatively small. And so that's where the individual who is diagnosed should isolate until it's deemed they can come back. And there's a lot of changes going on with that. We could talk about that in a minute, but then everyone else should just kind of monitor for the development of symptoms to see if they develop anything, and if they do, they should get tested right away. I think where it's trickier and where there's a little bit more nuance is if everyone was not wearing a mask, or if there was, it was in a room where you're doing an experiment and I didn't have a mask and I had the infection and you didn't have a mask, but because we're working on something, if we're fairly close, so within 6 feet, and it's been 15, 20 minutes that we were together, the best advice is that you actually quarantine and I'm isolated because I'm the one who was diagnosed with the infection. So that's where the difference with the mask and no mask. And that's where I think it's good to have kind of the cohorts, because the cohorts then, if there is a situation where you need to quarantine people, you quarantine small groups, or if you need to test, and this may be the next stage in testing, as Mike alluded to with like how we can get more tests, is doing pool testing. So you could pool the whole cohort, or you don't have to test that whole cohort individually as one, or everyone in the lab as one. But I think with mask, you can go on as business as usual. Without mask, I think you have to quarantine.
I think here we have got, when I look at a lot of the staff around, almost 100% of the people have got masks, and that's pretty good. I think we have been really implementing and enforcing that aspect of infection control.
Yeah, which is great.
But, just to follow up the question a little more, sometimes there is a gray zone. People wear masks, but sometimes they pull it out to eat, and if they work in a lab environment, and let's say you have one person, but that person interacts with another 4 or 5 people, and let's say they wear masks, but there is a gray zone there. Isn't it possible that, the other people who are asymptomatic might have given the infection to that person too, right? I mean, it could be an asymptomatic. How can you be sure that we let the other people, could it be the other way around? That person might have been infected by an asymptomatic other carrier in the lab. What I mean is, shouldn't we testing cohorts? Like the moment you have an exposure in a lab, will it make sense with the slightest doubt to have a low threshold to test everyone there?
Again, I think it would have to depend on a lot of different things. That's not what the university guidance has been.
No, I understand. Yeah.
And again, we have to follow the university guidance. They're also, in general, even within the hospital, we don't when there's a exposure here within the healthcare system, that's not the approach that we take if people are asymptomatic. Again, in part because people are wearing a mask, and the limited time that they're not, they should be maintaining distance to reduce the risk of transmission.
Okay, great. Thank you. A question.
Let me ask two questions that have come up from the committee, and I think maybe we can ask that.
Okay, all right, go ahead, go ahead.
Most of the infection control is that when people walk through the hospital, when they walk in, they get temperature checks. And we have had this discussion multiple times in the committee, whether we should have temperature checks in the Lurie research buildings or not, or just in general, when the people walk in or not. Okay.
I'll tell you my feeling about it. I'm not sure that the temperature adds probably a lot. I think if someone feels like they have a temperature, that is probably pretty good. And I think that kind of, even in the medical center, it's gotten a little looser with the temperature screens. So when we actually met with the person here in the hospital that manages the entire screening, and she didn't have a good sense of how many people screened because of fever. From what she told us, the biggest thing that people were screening positive for is because they took Tylenol or Advil, probably because they had a headache, and that's why they tweaked the question a little bit. So I think, the bigger issue is if someone's febrile, has respiratory illness, new loss of taste or smell, other respiratory symptoms, or aches, pains, isn't feeling well, they probably just shouldn't even come to work and talk with the PI in the lab to come up with a plan forward.
And I think there is something to be said about having to report to a colleague. So I think, having gone through the screening in the hospital for the past, since early March, having to confront a colleague, whether that's a nurse, another physician, whomever, and tell them that you're not experiencing those symptoms, I think it's actually pretty impactful, because you're telling someone else that you work with that that's relying on you to be as faithful as possible, and vice versa. And so it's the same way with a mask. I think it's this two-way street, and it's really powerful. And I agree with Mike, probably more so than these screens, because these screens more often than not just give you everyone's temperature is all the same. Oh, here's an outlier. And it's really hard to identify anyone from that, I think.
Okay, another question that we have is, how important is to wear a mask if you are outside and 6 feet apart? That's a question someone asked.
This is very simple. You should wear a mask unless you're in a room by yourself. No one anywhere in public can assure that you're not within 6 feet of someone else. Even if you're trying to stay at a distance, someone comes around a corner and is close to you. There is zero reason not to wear a mask anywhere but in your own office. Since March, I have had a mask on my face anytime when I'm not in my apartment or in my personal office. I'm fine. My face is not terribly irritated, and I haven't gotten infected. I think that it's not difficult. Just wear a mask.
Yeah,
I think that it's leadership. You're a Northwestern employee, and you wearing a mask is going to signal to your friends and family and other people around you that this is the right thing to do. And our biggest problem now is not enough people are wearing them. People don't take it seriously. But again, be a leader, do the right thing. And in the end, I wouldn't want to be responsible for other people getting sick if I got it. And I want to keep myself as protected as possible. So it's something you need to do.
Mike, do you want to add anything about that?
Yeah, no, I think that's perfect. And I think it's the idea that it's two-way. So when I wear a mask, I'm protecting myself from Mike, but I'm also protecting Mike from me. So that's the way that I look at it. And I think one of the best examples is all of us who've been in the hospital with all the patients with coronavirus, and how few of us have actually gotten this infection. And Mike could comment on the serology data that we've been looking at, but when you look at the numbers of employees that have been infected, it's low. And this has been repeated in Washington and New York, all over the place. So.
And I think that what is a little concerning these days is that you see less people with masks outside. even Northwestern employees. I have seen several cases, while a couple of months ago they were wearing masks, and and then you see now the numbers start coming up again in Chicago.
Yeah.
So that's an important. Another question that came up is, you mentioned the treatments that are emerging. There has been some recent evidence about inhaled interferon beta. There is a study in England that showed it has not been published yet, but preliminarily had very good. Do you think that could be something else that will emerge as treatment?
So the NIH clinical trial, so that's what gave us remdesivir. They currently just finished a study that it was remdesivir plus or minus baricitinib. So Act 3, they're done with the baricitinib. The next one is going to include interferon as an add-on to remdesivir. So I think we need to see that. We need large multi-center data for everything. I think the biggest thing that we learned is having a hunch about something is useless, and in fact can drive us to waste a lot of resources on studies that may not be helpful. I think we just need to be very supportive of doing clinical trials. There's a lot of things that may work. I think we're going to be moving into an era, the next set of trials are things that are specifically developed, not repurposed for COVID-19, monoclonal antibodies. There are 3 coronavirus-specific antivirals that are going to be entering clinical trials. This is where we need to be putting our effort into to get the field moving forward.
Yeah. Another question that has come up is, do you believe immune therapy, does that increase the risk for COVID, and to what extent, if it does?
Mike? So I think, a lot of it depends on kind of the specific immune therapy and the underlying factors in the individual. It's interesting when you look at the data, there's some hints that there's some of the immune therapies, the checkpoint inhibitors, may worsen the severity of the illness, but not impact mortality. There's other case series that have actually shown those individuals do a little bit better. So I think right now we don't really know for sure where the kind of scale is going to fall. Is it going to fall on the side of they're going to do worse or they're going to do better? I think this prompted some of the use of the Janus kinase inhibitors and stuff like that to really see, can they tamp down that response? And we had some personal experience with that. I think, to Mike's point, looking at the more global response and, did those agents affect it in any way that was worse, better, or had no impact? I think right now the approach should be anyone who's on immune therapy, chemotherapy, if you can stop it and hold it, I think you stop it and hold it. If it's one where they absolutely need to stay on it, I think you do it, but you do it with that caution of, if we have to stop it, we're going to stop it. If you start doing worse, we're going to stop it. We kind of learned this early on with our solid organ transplants, with manipulating the immune suppression. At first, we didn't do much reduction. Then we started to be really aggressive. And now we have this, let's be aggressive, but aggressive enough approach. And I think that's really helped out our solid organ. And I think the cancer patients with chemotherapy on the back end, as they start to recover, reintroducing that therapy. I think we've done a really good job of getting people back into treatment.
Thank you. One other question that just came is, how well are we doing contact tracing in Chicago and at Northwestern?
So at Northwestern, especially at the medical center, I think we are doing great as long as we know the person got sick. We have infection prevention and a whole corporate health group that does this. So I think that they've done a great job. City of Chicago, they've even admitted we're behind where we should be. They are starting to hire contact tracers. There was a piece I saw, I forget if it was this morning or yesterday morning, that Moraine Valley Community College has actually come up with their own system that they're going to let people use for free. That may help them. There was a lot of talk at the beginning about, COVID tracking apps, and there are, a lot of countries around the world that are using those, and the capability is on most of our phones. They just haven't been implemented for this. So it started, but we could probably be doing better outside Northwestern. I think in Northwestern, I think we're doing a pretty good job, as long as we know the person was sick.
Okay. And let me, we don't have any other question. Penny, let me ask one guess, if you can guess. When do you think there will be a vaccine? And when do you, if you can guess, that will have an impact on the disease?
So I have no idea. The reality
is a guess.
A lot of it will depend on, is there some safety signal? Is there some surprise in the development? The way things are going now, it looks like the first wave of a big phase 3 studies will be started in August. It'll take about a month for them to get started. They have a second vaccine, which is a month later, and then they have to be followed for antibodies and illness for a month or two afterwards. So that puts us probably like October, November by the time we have data out. And there'll be a lot of effort to look at this, analyze it, and get it to the FDA very quickly. They've done things to accelerate the production of the vaccine. That said, the current estimates from the companies and the government is that there'll be somewhere in the neighborhood of 10 million doses available by the end of January. Also, from looking at the kind of modeling that's being done by ACIP to prioritize who should get the vaccine first, and the kind of laying out of delivery of this, there's 12 million what they consider high priority people to vaccinate. So 10 million is less than the 12 million. So we're not going to be able to give the vaccine even to all the first frontline employees. There's likely to be 2 doses required. And so, that means that they won't be fully protected until they've gotten the second dose. It's estimated that we hit about 100 million doses somewhere March to April. There are 350 million people in the United States. So by the time we get everyone vaccinated, it's probably going to be next summer. And it may be a little later than that. The other thing that we don't know, how willing people are going to be to get the vaccine. Again, I personally think when people start talking about how some of these vaccines work, that's going to make a lot of people very nervous. And again, we need to do a good job. As many people have said, vaccines are amazing, but they don't work unless you get vaccinated. And so, how effective we are with the vaccine that we have, how quickly we roll it out, how effectively we get it to the people that need it, and how many people accept it is really the biggest unknowns.
Yeah.
Great. So it sounds that we better wear masks, everyone, all the time, So I don't think we have any more questions, and I would really like to thank both of you for great presentations and for addressing these important issues. Thank you so much again, and thank you everyone for coming to this event.
No problem. Thank you.
Yeah, no problem.
Bye-bye.
Thanks for having us. Thanks. Bye.
Thanks, Mike.
See you later, Mike.